very good evening and welcome everyone. I, Dr. Ritika Dhiman, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for today's discussion. On the occasion of Prostate Cancer Awareness Month, Voice of Healthcare, in association with AstraZeneca, has taken an initiative to bring together the experts and speakers for this resourceful discussion today, which aims to spread mass awareness on prostate cancer. With this discussion, we shall also dive into understanding the signs, symptoms, facts, and myths around prostate cancer, along with the impact of it on a patient's life. We will also be having the honor of having the direct patient voices with us, the cancer warriors with the journey of conquering the disease, and much more. I would like to commence this session by introducing our eminent speakers. Dr. Vivek Venkatramani, consultant, urologic oncologist, and robotic surgeon, Nanavati Superspeciality Hospital, Mumbai. Welcome, Dr. Vivek.
Thank you. Good evening.
Dr. Mukesh Rulaniya, Assistant Professor, Department of Medical Oncology and BMT, State Cancer Institute, SMS Medical College, Jaipur. Welcome, Dr. Mukesh.
Thanks, madam.
Dr. Javvid Muzamil, Consultant Oncologist, Medicare Superspeciality Hospital, Srinagar. Welcome, Dr. Javvid.
Good evening. Thank you, everyone.
Dr. Vikas Talreja, Consultant Specialist, Department of Medical Oncology and Hematology, Regency Hospital, Kanpur. Welcome, Dr. Vikas.
Very good evening and welcome everybody.
Along with sharing his views, Dr. Vikas will also be moderating today's session. Along with our esteemed panelists, we have two patient voices with us, Mr. Harlal and Mr. Raja Jahangir Ali Khan. So without further ado, over to you, Dr. Vikas.
A very warm evening to everybody. It is very important that we discuss this session today because prostate cancer, as we know, is one of the most common causes of cancer and is the sixth leading cause of the cancer deaths among the worldwide. If we look at across the world, prostate cancer burden is expected to grow to around 2 million cases and more than 5 lakh deaths by 2030, simply because the population that we are dealing with the prostate cancer is the aging population across the globe. Prostate cancer has become a very major problem across the industrialized world also, and also in the developing world, as it contributes to more than 3/4 of the registered cases across the globe. And incidence of this prostate cancer has nearly increased by more than 25-fold worldwide, the highest being in one among the Asian countries. And it was thought that previously that yes, prostate cancer was not much common, but yes, over the trends which we see in the last many years, metropolitan cities like Delhi, Kolkata, Pune, Trivandrum have been one of the most common sites where these prostate cancers has been reported, with an annual percent change of around 11% in urban districts as compared to around 10% in rural districts. So without further ado, it is very important that we discuss this disease, as it is much more common and much more worldwide, as it's a common problem in India, and I believe it's going to be a chronic disease for many years to come. And with such burden, I really am very grateful to the whole team AstraZeneca for giving us the platform on discussing this important issue among the most elite oncologists across the nation, and also to beautiful people around who have shared their journey throughout. So we will start with first a patient, Mr. Harlal Singh, who has been treated by Dr. Mukesh. हरलाल सिंह जी नमस्ते, मेरी आवाज आपको शायद सुनाई दे रही है?
नमस्ते सर।
बहुत ही बढ़िया,
बिल्कुल साफ दिखाई दे रही है सर।
बहुत ही बढ़िया। अच्छा हरलाल सिंह जी, मुझे थोड़ा अपने बारे में बताइए, आपको कब पता चला कि आपको ये बीमारी है, और आपने क्या चीजें पहले नोटिस की, और आप क्या मरीजों को बताना चाहते हैं कि भाई इनको ये दिक्कतें हो तो वो डॉक्टर को दिखाएं, कि भाई ताकि उनको भी ये बीमारी के बारे में थोड़ा जल्दी पता चल सके। हरलाल सिंह जी।
यस सर, सबसे पहले तो मैं सभी डॉक्टरों को मेरा नमस्कार
करना चाहता हूँ। और वैसे मैं मेरा परिचय देना चाहता हूँ। मेरा नाम हरलाल सिंह है, मैं सीकर से बिलोंग करता हूँ और राजस्थान रोडवेज में सर्विस करता हूँ। तो मैं सबसे पहले 2020 यानी नवंबर 2020 को मेरे को पेशाब में तकलीफ हुई थी। पहले तो ज्यादा पेशाब लग रहे थे, फिर पेशाब रुक जाते, ऐसे दिक्कत होती थी। तो मैंने सीकर में किसी डॉक्टर को दिखाया, तो उन्होंने पहले वो 12 mm की पथरी आई, तो पथरी निकाली, फिर दोबारा जाके चेक कराया, जैसे पेशाब वो नल की निकाली तो पेशाब नहीं लगे। फिर तो उन्होंने बोला कि रास्ता सफाई यानी TURP होगी, तो उन्होंने TURP कर दी। सेम 2 साल पहले दीपावली के दिन मेरी सर्जरी हुई है TURP की। जो TURP करने के बाद में जो कचरा जो ब्लॉक होते हैं वो जयपुर भेजा। जयपुर भेजने के बाद में उसमें एडिनोकार्सिनोमा आया। तो जैसे ही वो मेरे को पहले पता चला, फोन आया हॉस्पिटल से, बोले आपको तो ये क्या बीमारी होती है? बोले ये कैंसर होता है। तो मेरा ये से सन रह गया, मैं पहले देखता ही, नाम सुनते पहले मैं, हमारे परिवार में एक अंकल था, तो उनके जो ये गुर्दे के मान था, और 3 महीने बाद में वो डेथ हो गई उनकी। तो मैं परिवार पूरा डरा हुआ था, देखते ही मेरे को छन्न हो गए, मैं अभी वही और जिंदे नहीं रहेंगे। तो पहले मेरी वाइफ को बुलाया, मैं बुला के हिम्मत रखी और उसको बोला कि मेरे को ये बीमारी होगी, लेकिन अगर हम विश्वास रखें और हौसला रखें तो कुछ नहीं होगा, इलाज होता है। तो उन्होंने बताया। फिर मैं मुकेश जी से संपर्क किया जयपुर, और मुकेश जी से उनको दिखाया, तो उन्होंने बोला कि आपको ये कोई दिक्कत नहीं होगी। बहुत अच्छा विश्वास दिलाया मेरे को, कोई दिक्कत नहीं होगी, पेशेंट ठीक होते हैं और वो कोई दिक्कत नहीं, ये नॉर्मल है। तो उन्होंने बोला ये इसका ये रेडिएशन होगा। तो रेडिएशन करवाया पहले। रेडिएशन करने के बाद में हर 3 महीने बाद में मेरे को इंजेक्शन लगते हैं, और मैं आज बिल्कुल स्वस्थ हूँ। मैं कहता हूँ बिल्कुल एकदम। पहले तो बहुत यहाँ डर लगते थे, और एक और मेरे को जैसे कोई आम लोग जो पेशेंट से मिलने आते हैं लोग बाहर से, वो क्या उन्हीं की स्टोरी सुनाते हैं, जैसे पहले वो इस रोग से ग्रस्त है और उनकी डेथ हो गई है, तो वो आके पहले बोलते हैं कि वो इतने दिनों में वो चला गया, वो इतने दिनों में चला गया। तो पेशेंट क्या बोल अपने आप सोचता है कि अपने भी नंबर कब आएगा जाने। तो मैं बिल्कुल ऐसे जो मिलने अभिभावक से जो मिलने वाले थे, उनको जैसे फोन आया तो उनको मिलने के लिए मैं गया जाके। मैं बिल्कुल स्वस्थ हूँ। तो मेरा तो यही कहना है डॉक्टर साहब कि अगर हिम्मत है, हौसला है और डर, सबसे ज्यादा बीमारी का डर है, जो डर निकाल देता है और अपने डॉक्टर पे अच्छा विश्वास करके इलाज लेता है, तो इस बीमारी से अच्छा निजात पा सकता है। और मैं आज मुकेश जी को
बहुत
धन्यवाद देना
बहुत
चाहता हूँ।
धन्यवाद हरलाल सिंह जी का।
हाँ,
बहुत ही प्यारी बातें आपने हमसे कही। हम बातें करते रहेंगे, बट हमारे साथ
हाँ जी,
काफी सारे डॉक्टर्स जुड़े हैं। तो मेरा
जी,
सबसे
जी।
पहला सवाल डॉक्टर विवेक के लिए। डॉक्टर विवेक सर, we have seen that in last many years, many lifestyle changes has been there. Ours has country has become much more developed country, and we have day to day habits. So to people out there, how when can prevent this men related cancer, especially the prostate cancer, in the age groups it usually affects, that is in their later stages of life?
Thank you so much, Dr. Vikas, and thanks to the organizers for this opportunity. So, as you very, very rightly said, we are becoming more a westernized kind of, in terms of diet, exercise, sedentary lifestyle. All these lifestyle modifications have actually happened over the last generation or so. And because of that, numerous lifestyle diseases are what we are now also facing, in addition to our traditional diseases or tropical diseases as they are known. And as everyone knows, prevention is always better than cure. It's always better that you don't get the disease rather than having to treat it. So there are a few things that which we can all do in order to reduce the risk of prostate cancer, especially as a man ages. Because a lot of men, it's just a part of aging, and sometimes it will never affect them in their life. But there are a few things that we can do in order to reduce it. So first,
and foremost is smoking. So people probably don't realize, they just associate smoking with oral cancer or lung cancer, but actually even it raises the risk of prostate cancer about 2 or 3 times. So that is something which needs to be stopped. I think it's a habit which is really should be given up across the board. Even the moment you stop smoking, your health automatically improves by about 10-20%, and every year of being smoke free, it always improves the health. So that is one thing which I would always recommend. Second is in terms of patients always ask, sir, मैं क्या खा सकता हूँ, क्या पी सकता हूँ, what is healthy in terms of the diet. That's the most common question we get. So generally, there's as long as you are not overweight, that is one. Again, obesity is one of the risk factors for prostate cancer. So we need to, if possible, reduce the weight. That is one thing. Second, in terms of diet, there's no real specific link as such to prostate cancer, but anything which is good for the heart is also good for the prostate. That's what we are taught in urology, and that's what I generally tell the patients as well. So, less red meat, less fatty diet, less oily food, and increase in green vegetables. There's even some studies which show, cabbage and cauliflower have some beneficial effect for bladder cancer, but not so much yet for prostate. So, these kind of things which, reduce the salt intake, make sure your sugars are under control if you're diabetic. Everything that is healthy for your heart will be healthy for the prostate. So, diet, exercise. There is a study which shows that any exercise reduces your risk of any cancer, irrespective of weight. So just doing the activity also helps you to reduce the risk of cancer. So these are just basic things. And of course, men are notorious that जब तक कुछ बहुत ज्यादा problem नहीं होती है, तो they don't come to the doctor. So that is something that we must inculcate, that even if there's an early symptom, please come and get it checked out. Don't keep neglecting it. Patients often feel, अरे ये चला जाएगा, 10 दिन बाद देखेंगे, 1 महीने बाद देखेंगे, and by that time, things can progress, especially when it comes to a cancer. And last is general screening. What we know is that most Western organizations recommend screening for prostate cancer above the age of 50 or 55. So those men should get an annual PSA, and that would be something which would help us to catch it in a very early and treatable stage. So these are the few tips that can help us, to prevent or to catch it as quickly as possible.
Very well said, and very important points to be noted. I move to Dr. Mukesh. He has presented us with an excellent patient right away, and it gives me immense pleasure because he sees patients in a government setup also, and a lot of these patients come in a very advanced state by the time they reach to the center. So, why do you think, Dr. Mukesh, is an early diagnosis of cancer a still challenge in Indian population, and what are the symptoms you would like to put to the general audience as so that they can come early, especially for these men's-related cancer? How can be one more vigilant and be aware of these men's-related cancer? Is
I
Dr.
think
Mukesh around?
we have lost. Yes, Dr. Mukesh is
No
there.
issues, no issues. So we'll move to, by the time he rejoins us, I will move to Dr. Javed,
Trying to
sir.
join.
Perfect.
Yeah, Vikas sir, please, because of network issue, please repeat the question.
Sorry. So
Yeah.
we see a lot of these patients coming in advanced stages, in stages where offering them a curative treatment is sometimes very difficult. So how one needs to be much more vigilant, how one can identify an early signs and symptoms of this disease, especially the men's-related cancer, and especially in a country where India, where most of us them are financially challenged, screening programs are not universal, and it becomes very difficult to implement in next few years for the screening for the men's-related cancer. What's your go-to advice for the same? There is certain issue with Dr. Mukesh.
Yes, I think there is an internet issue with him.
No issues. We will
Yeah.
move to Dr. Has he joined again?
Yeah, yeah. I am sorry. Again, network issue. Please, once again, sir.
So why do you think in India people do present in an advanced state? What is your recommendation for screening them early? And what are the early signs and symptoms you would like to point out for an early diagnosis of men's-related cancer?
So today, especially because we talk about prostate cancer, so I first talk about prostate cancer. And we in our clinical, especially government setting, see that majority of prostate cancer patients are present in late stage. Because majority of patients have no symptoms in initial stages, and patients are think that this is normal things like excessive urination at night or daytimes, dribbling of urine, back pain. Patient think that is maybe due to uh, prostate megaly and maybe not due to another reason, but they never think about prostate cancers. So due to that reasons, patient ignore that symptoms and they usually present in stage 4 bony metastasis, excessive bony pain, and then present to doctor and then underwent MRI and they saw their bony metastasis. So especially in prostate cancer settings, majority of in our settings are present in stage 4
Thank you, sir.
and usually are adult or older peoples. But in other cancers in men's, they usually are symptomatic. Like if we see the lung cancers, the majority of patients in especially in, also in early staging, they can maybe present with cough and dyspnea, sometimes hoarseness of voice, and like I think you talk about GI cancers, they present with abnormal GI function like constipation, diarrhea, and recurrent vomiting, loss of appetite, decrease weight, and if the patient suffering from hepatocellular carcinoma, then again loss of appetite, weight loss, generalized weakness, abdominal fullness. So usually in men's related cancers, symptoms present in earlier stages, but especially in prostate cancers, the symptoms are usually absent in earlier stages. Mainly symptoms are present in late stage. But if I talk about in Indian settings, especially in Indian settings, usually no male are underwent screening for prostate cancers because there are no as we saw in majority of guidelines, there are no category 1 recommendation for prostate cancer screening because of no specific or sensitive test to detect prostate cancer earlier stages, and because prostate cancer usually a slow growing course, so patient are, if we guide and we counseling, so patient are also ignoring. So in Indian settings, they're difficult to screen for prostate cancers, but we aware about the symptoms. If there is symptoms specific to prostate cancer, they should consult earliest as to doctors.
Very well said, and I must say that Dr. Mukesh has tell us the ground reality of what the most Indian doctors faces across the country, and we will begin with the crown of the country. The Dr. Javvid sir here is with us. He has been quite an experience right now, and one of the most common challenges which we face, especially in a third world country like India, is the finances, and most of these patients are during that time of treatment when they retire the government beneficiary or be any beneficiaries where the medical treatment is not supported by the organization which they have worked for many years. So Dr. Javed will highlight us about various cost related issues, especially for these patients, for their treatment, for their diagnosis, for the investigations. Dr. Javed, sir, please.
Yeah, thank you, Dr. Vikas and AstraZeneca team. This is very important that this disease comes at a stage once job is once a patient is retiring from the job, if he's in government or private. So that's the problem, and that is that part of the life when his their daughters or sons are that time, most of the times they are idle, and he want to give them some job, so again he needs money that time. And maybe a daughter is getting married, so he needs money for that. So at a suddenly there is this financial burden on this patient at that time. So it's very difficult. But one reason could be that most of our let's leave these ECHS patients and those patients which are covered by some other insurance. So health insurance has to be there for each and everybody. I think that will be the solution for each and every patient. Because if we cover health insurance for all the general population, so there won't be any problem. And we know that prostate cancer treatment is not that costly now, so that can be managed with PSA testing is not costly, ultrasound is not costly, CT and MRIs are not now that costly. But if you have an health insurance, that is one thing, that health insurance and putting the policies in such a way that each and everybody will go for the health insurance, so that at the end of this once a patient is retiring and nobody is reimbursing then those investigation costs or treatment costs at the end. So better is to have this health insurance, have an 5 lakh 10 lakh health insurance, so that this will become one of the share for him, that he can take all the treatment burdens because of that health insurance. And second part of that is that looking at our state, Jammu and Kashmir, and for the last 2.5 years, we have been given a special this Ayushman Bharat scheme. So each and everybody is covered with the Ayushman Bharat scheme. So we don't have any problems in investigating or delivering the treatment, whether it comes radiotherapy or urology surgical part or medical therapies. Even though medical castration is also included, including is there 2 lines of chemotherapy and 1 line of the hormonal treatment. So for J&K, I think we are very much well placed as far as the prostate cancer is concerned. Yes, if we talk of the higher treatments like this, we need to do the isotope scanning. That's not covered. Yes, that PSM is this one test. We know that it may be 35 to 45,000. So it depends upon the state where you are doing that test. So that part we don't have here, and that's not covered by this Ayushman Bharat scheme as well. So, nutshell, that health insurance, that's very important. Yes, savings from the early life, from 30 to 40 years of life savings, that is important. And second, health insurance, I think that will be the answer to most of the Indian patients if we have on right time, so that we can share the burden of all the finances that are incurred during the treatment.
Very well said. I must say that Dr. Uh, Muzamil sir is lucky to have Ayushman at their center, but not every doctor is that much lucky to have Ayushman at their centers. And I believe we have a corollary with Dr. Vivek, who specializes in a corporate hospital. So, Dr. Vivek, do you think that what Dr. Muzamil pointed out, that yes, there should be a universal healthcare for these, and what are your counterpart of difficulties as when you want to offer a standard of care to a patient, and then the patient says that there are financial restrictions to what your standard of care is? Do you think are there any existing models where you feel that they can you can accommodate your standard of care along with without any financial burdens at your place?
Right. Thank you so much for that question. And I think half my work has been done by Dr. Muzamil sir. He answered it perfectly. So you are absolutely right. Urology cancers by default are expensive cancers. Bladder cancer is the most expensive cancer to have because you have to do regular cystoscopies. Similarly, prostate cancer, now we have got 1 line, 2 line, 3 line, 4 line, 5 line. There's no end. So actually, it keeps, and each line keeps getting more and more expensive as we go down. So there is always a risk of the patient. Financial toxicity is now coming up as an endpoint in studies, that which of the treatments are actually cost effective as compared to the others. So these are some things that really need to be studied. And of course, health insurance is the number one way to go if that's possible. A lot of central government employees do also come to us. A lot of corporates send their patients to us. So employers do cover a lot of the treatment in bigger cities especially. So that is one advantage we have. Then there are these schemes of Prime Minister's Fund, Chief Minister's Fund, which can also help to bridge the gap between what we want to do and what the patient can afford. Nowadays, actually, there is a circular by IRDA which says that all health insurance have to approve robotic surgery for especially for cancer indications. But still, the insurance companies, they don't approve. They create some excuse. So it is up to us as doctors to give the patient a proper letter, give the justification for the treatment, and then they should get the approval for all these advanced treatments as well. So nowadays also a lot of crowdfunding is going on. You create a plea to the patients. A lot of people do contribute, and we are able to get treatments even in lower socioeconomic status, which allows absolutely state of the art treatment to be provided. And lastly, a lot of the companies do have some patient assistant programs also. So if the patient is able to get 3 months drug, they give 1 month free. They give some medications free. So everybody actually as a society is trying to contribute to improve the accessibility of these things for cancer patients. Ultimately, universal healthcare, if it's still a big dream. Our GDP spending on health is still very low. It can be improved. We need to have insurance coverage well permeated throughout all the society. That will also be a real boon for our patients, actually.
Very well said. A very important points highlighted for universal healthcare, updation of the insurance policies, and also regarding the easily reimbursement of those who are having universal healthcare. Um, but for those who don't have the access, and universal healthcare is a distant dream, I believe picking them early and treating them early is something which we would be doing. And for that, we need a definitely a good screening for in the general population as per se. But in India, what one majorly encounters are the no universal screening, especially for the men-related cancer. And there, Dr. Javed will help us is what his advice for a regular screening, and what his advice to the government and the national authority out there for screening of these cancers in India.
Okay, that we are that what is the how do we screen the prostate cancer, and how we go ahead with these patients, how we try to uh, get these as early as possible. That's the question. So we know that screening dictum of screening in prostate cancer, it's very controversial, and it all depends upon the life expectancy of a patient. So these patients, once they get this disease, that most of the times it will be 60, 65. So as far as the longevity is concerned now, where this lifespan has increased at least by 10 years. So we are seeing these disease more than these 55 to 60 years. So there they have that time associated with symptoms related to with some other disease, like they have diabetes and diabetes associated complications, hypertension associated complications, and many other things. So we have to assess the comorbidity status before we look on the that we should screen these patients. Yes, one important thing is that yes, screening will pick up the things, will pick up the disease, any disease as early, and you will treat these patients accordingly. So again, the treatment part we will discuss later on. Simple way of screening, as we have this prostate specific antigen, a simple blood test, and that's being done everywhere in each corner of the country. So 1 to 2 ml of the blood is taken by any technician, and by the evening the patient gets the report, or a person gets the report. So annually, we are saying that we will screen each and every. Yes, at least one test should be done after 50 years of age. Yes, it is abnormal, then one will proceed. If it is not abnormal, okay, one may relax. And there are some instances that prostate cancer can have normal PSA, but the disease is maybe sometimes localized, or it has spread, but with normal PSA. These are the rare instances. In that case, it should one DRE is to be done. So this digital rectal examination is not part of the screening. So very easy in our setup is that get one PSA done and then follow accordingly, yearly, 2 yearly, 3 yearly, depends upon the risk of the population. So we have to see which people we have to actually screen. It depends upon of their risk. So one risk is that what is the family history? Is there any malignancy in the family, any prostate cancer in the family, any pancreatic, or any breast associated disease, or ovarian in the females? So maybe they are harboring some genetic mutation. So in them, you have to come 10 years earlier than that of what is the usual screening of the 50 to 55 years. So in Western countries, they have kept a screening age of at 40 in high risk population. Otherwise, for general public, it is beyond 45. So we don't have such kind of screening here. And how we'll make this awareness is that we will use mass awareness in public in the form of the, as we do social through social media, through television, through print media. What's prostate cancer, how we treat it, how can we pick up this as early as possible, so that less invasive treatments are available, less cost will be needed for the this kind of the treatment. And another important thing is that in our this ICDS this tree, we have ASHA workers that are, I think, in each and every village in urban as well as rural setup. So ASHA workers, they are very close to each and every family in their locality. So better is to this educate those, and so that they will go from one home to another home in their locality, and they will collect the status. And by educating them is almost educating each and every this male patient or a female patient at in their locality. And second is they collaborating with the labs, and labs are everywhere now. So just making a camp, and with the help of the ASHA workers, and get the samples done by the evening. If we get one locality at one time, so we'll have 100 samples, and we'll have results by the evening. So by that you can see what is the incidence, and how is prostate cancer in our this society. So that's how. And by once we know the quantum of the disease, and by means of the screening, and we can make policies like the by that, and so that the government also will come forward and make some policies for those patients as well, in terms of their this health policies and all those things.
If government is listening right now, I believe very important points being laid out, very crystal clear, and very important roadmap for a lot of things to be worked upon. It does need a very important foundation for building up your infrastructure for a universal screening with a very simple PSA, and yeah, to make it available and applicable to every population who needs it. Dr. Vivek, do you think family history is important in prostate cancer? And what is the role of family history in prostate cancer?
Right. So I think Dr. Javed also touched upon it a little bit. So family history actually doubles the risk of prostate cancer in a particular individual. So normal risk is about 1 is to 8 men will ultimately develop prostate cancer in their lives. And if you have a positive family history, it goes up to 1 is to 3. So especially first degree relatives, so father, brother, those are the first degree relatives which are important. Then in the extended family, if there are 3 successive generations of men, either on the father or mother's side, that is another risk factor for prostate cancer. Somebody in your family who has died of prostate cancer, that suggests that these are more aggressive variants. So these are all risk factors which would prompt a person to seek screening a little earlier than usual, maybe in the 40s. So the recommendation is those with a strong family history to get the PSA at 40. If it is less than 1, then the risk is very low. They can go restart at 55. But if it is more than 1.5, then they need to be very stringently watched even in their 40s. So that is something called familial prostate cancer. Of course, a significant genetic component as well, as we are learning over the last 3 to 4 years for prostate cancer. So there are a number of genes, almost 10 to 11% of prostate cancer may be associated with specific genetic mutations, which can be either sporadic or which may be transmitted through the family. So these are mutations which are common with other cancers. So breast cancer, ovarian cancer, pancreatic cancer, Lynch syndrome, and upper tract urothelial cancers or GI cancers. So these are all things which, if they are found in the family, may suggest a genetic component to the patient's prostate cancer. So these are seen only in about 10 to 11%, but especially today, because we have drugs and more treatments available, which may be able to be used to target these particular mutations, the genetic history and the family history are making a bigger and bigger impact and playing a bigger role, not just in history, but even in the further management of these patients. So if you detect BRCA1 and 2 mutations, if you detect HRR mutations, so all these things, MSH mutations, all these mutations play a role. As medical oncologists, I think I don't need to tell y'all know much more than me about all this. But these are the ways in which we can, actually target specific molecules for the patient's further treatment, and that is going to ultimately lead us to maybe an era of individualized or personalized cancer care, where you genotype the tumor, see what are the mutations and what would be the best kind of treatment that that patient can particularly receive. So that is coming maybe 5-10 years in the future. But as clinicians, we must remember to take a good family history of the patient, because that is something which can contribute. So BRCA2 is associated with more lethal tumors, more aggressive tumors for the prostate. So, if there is any such suggestion, get the patient screened. Nowadays, it's not that expensive. The Indian labs do provide the genetic screening at a fairly, competitive cost. So, especially in those who present in an advanced state or in an early setting, early age, then it may be worthwhile even doing the genetic screening at the time of diagnosis. So this is where prostate cancer is heading. I think it's similar to the other cancers in different parts of the body. So family history, genetic history, counseling the patient, all these are very, very critical parts nowadays when we see a prostate cancer patient. No more we can just forget about this part of the history.
As very importantly said, family history does play a very important role in predicting the nature of the future directions of prostate cancer. Dr. Mukesh, who do you usually advise genetic testing in your routine patients, and when do you usually advise them?
So, sir, especially I advise is genetic testing for patients with early stage prostate cancer that are high risk or very high risk, and if a patient is metastatic settings, because there is definitely a prognostic and therapeutic benefit in metastatic setting, because many targeted therapies are available currently in BRCA and HRR positive patients. So I usually recommend a patient a metastatic presented with metastatic. I usually recommend HRR testing, and sometimes some patients are present usually high risk one, very high risk setting in early stage prostate cancer. Then again I recommend for BRCA testing and HRR testings.
Very well said. Mr. Jahangir sir is waiting for a quite long time. जहांगीर सर, नमस्ते. आप अपने बारे में सर बताइए थोड़ा कि आपको इस बीमारी ने कब अफेक्ट किया और आप को आपकी दुनिया कैसे बदली गई इस बीमारी के साथ में. जहांगीर जी.
बहुत शुक्रिया सरकार. आवाज आ रही है मेरी आपको?
बिल्कुल, बहुत साफ.
हुजूर वाला शान मैंने अपने, मेरी बच्ची भी डॉक्टर है, मेरे भाई भी डॉक्टर हैं, फिर अपने दोस्त अहबाब रिश्तों में भी डॉक्टर्स हैं. तो कुछ चेक्स के लिए हम गए तो कहा कि भाई ये एज ही ऐसी है. मैं कोई 73 साल की उम्र में हूँ इस वक्त. तो मैं कुछ अपने बारे में बताऊं. आई एम मोर ए स्पोर्ट्समैन देन ए लॉयर एंड एडवोकेट. स्पोर्ट्समैन इसलिए कि मेरा स्विमिंग रिकॉर्ड कोई 10 किलोमीटर का नॉन स्टॉप है. आई एम चेयरमैन माउंटेनियरिंग क्लब हियर इन द स्टेट.
We have lost the connection, I think.
बैकएंड टीम में कोई हेल्प कर सकता है उनको?
हाँ जहांगीर साहब
जी, आप कॉल आ गई थी, अमेरिका से किसी कॉल थी, आप काट दिया हमने. सरकार, मुझे जब ये पता चला कि मेरे फ्लो में कुछ फर्क है तो टेस्ट हो गए. लोगों ने कहा कि भी डॉक्टर्स अपने हैं, डॉक्टर सलीम वानी साहब हैं, उन्होंने कहा कि भाई ये एज ही ऐसी है कि इसमें प्रोस्टेट का ग्रेड जरा चेंज हो जाता है, उस वजह से. और कुछ दवाई दी उन्होंने तो मैंने ले ली, मुझे कोई फर्क नहीं हो गया. इसके अलावा मैं आपको बताऊं, मैं जिस रोज मुझे ये टेस्ट कंप्लीट होके पता चला कि भाई कैंसर इस स्टेज पे है, उस रोज भी मैं कोई 8-9 किलोमीटर सुबह जॉगिंग मैंने की है. यकीन कीजिए, किसी तरह का कोई दर्द इस एज में भी, किसी तरह का कोई दर्द में, हालांकि मैं पैरास्टामॉल भी नहीं खाता था, कोई दर्द नहीं, न कोई दर्द, न कोई खाने पीने में तकलीफ, न कोई हाजिमे में तकलीफ, किसी तरह की कोई ये मुझे परेशानी नहीं थी. जब ये पता चला तो उसके बाद मैं दिल्ली चला गया. दिल्ली मेरे अपने रिश्ते में डॉक्टर सईद आसिम रजवी वहाँ है, रोबोटिक सर्जन है इस अपोलो में. तो उन्होंने काफी हमारी जो है वो की. डॉक्टर दीपांजन पांडा है एक वहाँ पे अपोलो में, और मनीष सिंगल है. खैर मेरा ट्रीटमेंट शुरू हो गया. उसके बाद मेरे 2019 में और एक सर्जरी हो गई टर्प की, और जुलाई 2020 में भी सर्जरी हो गई. उसके बाद जो है ट्रीटमेंट आगे चला, जिसमें इन्होंने दिल्ली में कहा कि इसमें कुछ हार्मोनल टाइप का ट्रीटमेंट करना है. लेकिन मेरी वो हालत देख के जाहिरी कोई दिखाई नहीं देता कि मैं बीमार हूं, और इस कदर शिद्दत से बीमार हूं. तो मेरी क्या कहते हैं वहां पे रेडिएशन 16 फ्रैक्शंस मेरे रेडिएशन मैक्स में हो गए. डॉक्टर गगन सैनी साहब थे वहां, उन्होंने कहा कि भाई आपको क्या तकलीफ है? मैंने कहा मुझे कोई तकलीफ नहीं है, किसी तरह की कोई तकलीफ नहीं है. 73 साल मेरी उम्र है. मैं एक बिल्कुल अपने से 20 साल 25 साल के नौजवानों से बेहतर मेरी एक्टिविटीज है. हर तरह की एक्टिविटी, स्विमिंग की एक्टिविटी, माउंटेनियरिंग की एक्टिविटी. मैं शिकार क्लब का चेयरमैन यहाँ हूँ. तो यकीन नहीं आ गया. मैंने कहा मुझे जाहिरी कोई बीमारी तो नहीं लग रही है, लेकिन मेरा रिकॉर्ड बता रहा है कि मैं बहुत सीरियस बीमार हूँ. तो कहा कि भाई इस एज में तो हम ये रेडिएशन करते नहीं है जो उन्होंने बताया, लेकिन आपका हम कर लेंगे. बहरहाल 16 फ्रैक्शंस के बाद उन्होंने मुझे तसल्ली दे दी कि भाई मेरी नजर में तो आपका अब कुछ बाकी नहीं रहा है, बिल्कुल ठीक है. उसके बाद मेरा कीमोथेरेपी शुरू हुआ. कीमोथेरेपी कुछ वक्त के लिए हमने 2020 में कर लिया. 20-21 दिन के बाद एक मेरा लगता था उसका कीमो का. तो वहां से मैंने कहा भाई गर्मियां बहुत है, अगर श्रीनगर में मेरे लिए इसके लिए कुछ इंतजाम है, अगर आप सजेस्ट करते हैं तो मैं श्रीनगर में कर लूं. तो वहां से आके मैंने डॉक्टर जावेद मुजमिल साहब से राबिता किया, तो इन्होंने मेरे रिपोर्ट देखे, भाई आप माशाल्लाह बिल्कुल ठीक हैं, तो लेकिन ये कीमो कुछ कर लीजिए। अब देखिए हर 6 महीने के बाद मेरा पेट स्कैनिंग हुआ, 2 साल से हो रहा है, और हर बार इन्होंने कहा आप बिल्कुल ठीक हैं, आपको कुछ भी नहीं है। तो दवा मुझे कुछ इंजेक्शन लगते थे, कीमो होता था, अब तकरीबन 8-9 महीने से मेरा कोई कीमो नहीं है। अक्टूबर में, अभी अक्टूबर आ रहा है, मेरा 6 मंथली चेक फिर से ड्यू हो गया है, मैं जाके देख लूंगा अल्लाह को क्या मंजूर होगा। वैसे अभी तक के हालात में कोई मुझे अल्हम्दुलिल्लाह न कोई भूख की परेशानी है, मैं ठीक से खाता हूँ, ठीक से सोता हूँ, ठीक से मेरी जॉगिंग एक्सरसाइज वगैरह नॉर्मल लाइफ है। तो ये हालात हैं।
बहुत ही बढ़िया, बहुत ही बढ़िया, बहुत ही उम्दा आपने बातें कही हैं, और
जी
ऐसी बातें कही हैं जो बहुत मरीजों को इनकरेज करेगा कि बीमारी आपसे नहीं है, आप बीमारी के ऊपर हैं,
आप
और आपकी ज़िंदगी उसके ऊपर आगे भी बहुत नॉर्मल रह सकती है। हम
मेरे भाईजान,
समय के
मैं एक जस्ट 1 मिनट। मैं 2020-21 में जब कोविड अपने उरूज पे था, चारों तरफ से कब्रिस्तान और शमशान घाट्स में क्रीमेशन की कोई वो टर्न भी नहीं मिलती थी, मुझे कोविड हो गया, कोविड पॉजिटिव हुआ, मेरा नमूनिया हो गया, बायोलेटरल नमूनिया। लेकिन मेरे भाई जो डॉक्टर हैं वो भी अच्छे सीनियर डॉक्टर हैं, उन्होंने इंजेक्शन 5 किए, मुझे क्या नहीं, 5वें दिन मेरा नमूनिया भी क्लियर था, मैं उससे भी निकला, अल्लाह ने उसमें भी मेरी रफाकत की, मेरा एहसान है अल्लाह का मुझ पे। जी हाँ। तो
बहुत ही
मैं पेशेंट्स के लिए मेरी एक सजेशन है कि जित खैर आप तो खैर माशाल्लाह ये शर्फ मुझे हासिल है कि एक साथ मुझे इतने डॉक्टर्स के साथ मुलाकात हो गई, खासतौर पे डॉक्टर मुजमिल साहब तो यही है, वो हमारा पूरी तरह से जब भी हम जाएं तो बहुत ही अच्छा, बहुत ही बेहतरीन सलीके से उनका पे हर एक पेशेंट के साथ, मेरे साथ भी ये है, तो काफी हौसला अफजाई उनकी होती है। तो इंशाल्लाह मैं जाहिर सूरत में तो मुझे कोई परेशानी नहीं है, कोई बीमारी नहीं है। तो आपकी दुआ है आप लोगों की, मुझे बड़ी खुशी है कि एक साथ इतने डॉक्टर्स मुझे सामने हैं जो मुझे सुन रहे हैं, और मुझे अब जैसे भी हो मुझे मेरी हौसला अफजाई कर लेंगे, हर एक पेशेंट की हौसला अफजाई कर रहा हूँ।
सिर्फ डॉक्टर्स ही नहीं, पूरी दुनिया आपको सुन रही है और आपकी बातों को एक इंस्पिरेशन की तरह ली जा रही है।
जी
और
जी
मैं अब डॉक्टर मुजमिल से आखिरी सवाल पूछूंगा कि आ, जहांगीर जी किस्मत वाले थे कि इनकी तबीयत और बॉडी इस तरह से थी कि सब कुछ झेल पाई, बट मैनी ऑफ आर पेशेंट्स डू कम इन अ वेरी एडवांस स्टेट। सो डॉक्टर मुजमिल सर, what happens when we don't treat these patients? What are the usual complications? How they usually present in an advanced state, and what are the most things you see commonly when they come to you in an advanced stage of disease? Dr. Muzamil sir.
Yeah. So we are discussing about the early detection versus late detection. So early detection, I already said that we have to see the life expectancy that time. If we have more than 10 years of life expectancy, then we should treat these patients. Less than 10 years of life expectancy, okay, comorbid state is there. This patient is not going to die because of the prostate cancer death. Now, coming to the late detection, yes, as Dr. Mukesh also said once he talked that some patients come to you, they ignore the symptoms, go on ignoring the symptoms, and suddenly there is a retention of urine, and there is a backache also. So these patients, we see them that once we do MRI checkup, and we see that yes, there's a cord compression. He has one of the metastasis in the vertebral column, and that is compressing the cord and is giving rise to one retention of urine and the complete paralysis of both the lower limbs. So that we call as an paraparesis. So that is one of the problem that the we don't talk of here survival, we talk of here the quality of life. So their quality of life is miserable if they develop paraparesis, and that paraparesis stays for more than 10 to 15 days once you are not going to take care of that, and it becomes an irreversible sort of thing. And I've seen many patients having such thing. And some patients I have seen that somebody had cervical cord this compression because of the metastasis, or somebody has neck of this femur fracture or some long bone fracture because of the trivial trauma, and then he investigated, and we saw that it is because of the prostate cancer. So in order to prevent these things, these life accidents, and then be the burden on the family, and there comes the role of the early detection of this advanced disease and treat them as early as possible, provide radiotherapy to sites where which are very very weak because of the metastasis, whether it is in long bones, whether it is in the vertebral column. Most of the times it is in the axial skeleton only. And sometimes, and we have seen that patient might present with brain metastasis, very rare, but once there is metastasis everywhere, so they can present disease anywhere else as well. So crux of the story is that in order to improve the quality of life, we should detect these patients as early as possible and treat them as early as possible, whether we give symptomatic treatment, whether we give targeted treatment, to improve their quality of life. We have so many drugs now available, we have radiation available, we have surgery available. Sometimes we have to just fix the these axial skeleton by means of screws that orthopedician or neurosurgeon does, and stabilize the spine so that the patient won't develop the cord compression. We have hormonal treatments, as Dr. This Jahangir Saab rightly said. He has tolerated so many chemotherapies. Basically, he had a neuroendocrine variant, but Alhamdulillah, he's very good. He's fine, and he's coping up with all the toxicities, and he's absolutely fine at present. So that belief one patient has to have on his clinician, so that there won't be any problem in future. So he tries to, because the physician, each every physician tries to make a such a kind of protocol for the patient so that his patient lives long and with a good quality of life. That is our job. So rest is all in the hands of Almighty.
Beautiful words said by Dr. Muzamil sir. We all know that prostate cancer now is a very chronic problem, especially with the changing lifestyles, increasing awareness, easy access to the medical facilities. More cases of prostate cancer are being picked up, and it is coming to the knowledge that we are not very far behind the Western countries for the same. The registries are reporting it. The diagnostic and detection technologies have improved, and more population right now has an access and also an affordability for the same. Therefore, a correct and complete knowledge of the whole prostate cancer, its epidemiology, its treatment, and also its approaches is very important in helping policymakers and concerned authorities to plan and formulate sound care cancer control strategies based on the scientific and the empirical basis. I thank whole of my panel, Dr. Muzamil sir, Dr. Vivek, Dr. Mukesh, for shedding a very important light on spreading the mass awareness of the prostate cancer in men, and also Jahangir sir and Halal ji for important patient perspectives for the prostate cancers. With this, we bring an end to the a very important program, which was very informed and very intellectually driven for me and also all the audience out there. Thank you. Wish you a very good evening, and over to the organizers for the conclusions.